delighted to introduce our next fabulous speaker, Andy Phillips, is a PhD. Dr. Phillips is an assistant professor at the MGH Institute of Health Professions School of Nursing, where he teaches, of course, nursing informatics and research methods. He also holds an adjunct appointment as the assistant professor of nursing at Columbia University School of Nursing, where he teaches health policy. Thank you very much, Andy.
Keeping it short today, all right? All right. So 2 years ago, I wasn't here. And as a result of that, I'm doing this every year. So you need to be here every single year. All right. So some of the skills that were left out from just the teaching stuff is I can read a lot very fast. And what was the other one? I wrote it down when I was thinking there, but I can't remember what it is now. So memory is not one of them. So having listened to our first three speakers, a couple things came to mind. One, you've said everything I'm going to say, so we could finish here and have dessert, some more lunch. But more importantly, I get to validate everything they say through a lot of the research that's been done over the last year. So that's how I'm going to look at it, that I'm validating what you just heard and trying to emphasize some of the things that are out there in the literature. So what we've done in the past is, you already said this about everyone, but that's a doodle of all the words from all the titles from the X number of articles that I looked at. So nursing health, not shocking, but there's some in there if you look at the little ones, which you can't see. So implementation, information, whatever. Feasibility, there's one. So I like methods, right? In my introduction, it says I teach methods, right? So there has to be a method to this, and I'm going to go real quick, but I like having things that have a method. So the method I adopted is a scoping study, which is really what it is. I used Arski's and O'Malley's method. There's 6 steps. I'm not going to read them all, but we're going to go through each of the 6 steps. So the first thing is a research question, and I'm talking fast because I have half an hour. And if you don't understand me, I'm from New York, and you just say, hey, can you slow down? So what trends and themes emerged from the survey, and how can we make meaning of all of these publications that took place over the last year? So identifying relevant studies, this is the exact terminology I used. Nursing and informatics or nursing informatics. And it turns out it produces a lot of papers, all right? So I'm thinking of changing that to something more concise. But listening to some of the speakers, maybe this is too confining. Maybe we need to be looking at different kinds of things. We have different roles. We had Dan talking about data scientist, have that right? So maybe we need to be looking at different kinds of things. I think if I add nursing data scientists, as I understand it, it won't change any of my outcomes. So I can at least throw that out there. So we look at the prior dates. So every year we look at the prior year of data, and then I do my fancy stuff and I come up with some answers. One thing I do want to note is that this conference is 3 weeks earlier than last year's conference. Which just tells you that skill I have of reading really fast. All right, so the inclusion has to be research, has to contribute to nursing, informatics knowledge base, maybe some prototype development, testing, clinical care delivery, informatics. I'm not looking at articles that deal with educational programs, nursing education, nursing students, those kinds of things. I'm trying to keep it on at a slightly higher level, not that students aren't at a high level. I was a student once, and I think I was at the tippy top level. But that's the thing we're looking at. And the key number here is 726, right? I had to look at 726 articles. So since March 1st. So just keep that in mind as you look at that. Fortunately, 40 were duplicates, so I only had 686 after that. I only had to read the abstracts first. I got rid of 479 from reading the abstracts. I did have to then look at 207 articles and see if they met those inclusion criteria. And the thing you learn is that you learn a lot, which is why I like doing this, is that I actually learn a lot about what's happening in nursing informatics and informatics in general over the past year and kind of see where the trends are and what's been happening. As I said, the prior 3 speakers pretty much stole my thunder on what's happening. So 44 I couldn't find, or the library decided that they're not going to let me get at it or whatever. And we ended up with 163 articles to review the full text. So that's what I did. Looked at 163 articles, tried to develop some themes that we could then talk about. So that's the trend. I took over at about the 129, so, and it's still going up. It's now up to 163. I did adopt a new methodology, as I just told you about, scoping study, which tries to get a much better, a much larger bandwidth of articles. So I would expect it to go up, but I'm hoping it kind of levels off a little bit up there, around 163. Or we delay, go back to the May meeting rather than the April meeting. In keeping with tradition, we have pie charts. And just to give a thing, with colors that you can't distinguish, right? Which is why you don't use pie charts, right? But I'll give you a hint. The biggest one there is hospitals. So most of these studies took place within a hospital setting. And then here are the settings. You know, this is tradition, right? This group has, 16 years of tradition? And who am I to say we shouldn't continue these bar charts every single year? All right? But there's some interesting things to talk about here, just quickly as far as trends. One of the things we used to keep track of was ambulatory and continuum of care. I'm getting really confused as to which is which at this point, because I think that as hospital stays become shorter, we push more people into ambulatory care. Where do we end up drawing that line? So I just threw everything in ambulatory care. So those are kind of combined together, and if you would like to read 163 articles, we can debate whether that was the correct thing to do or not. Community and public health is a little higher, and again, as we have more access to data, we have more data out there. We're going to start, I hope to see that go up significantly, because I think population health, we had 2 presenters at least put that social determinants of health model up there, where only 10% is medicine and this huge number is everything else. If we're not looking at it, then how are we going to start addressing that huge number? So that has to go up. That community and public health number, we need more research and studies around that. Again, hospitalization is still the biggest category there. I would also hope that we could see some more on the long-term care side. We have an aging population. We need to start looking at that. They weren't part of meaningful use, and that's no excuse to have them kind of deteriorate down to 2% last year. Same thing with other. Other was 1%. I'm not sure what that tells you. I just happened to circle it on my page here. But one thing that is interesting is that these are all the countries that research is coming from now. Look at all of those countries. Obviously, a lot of it is coming from the US, but this is a huge number of countries where research is coming from. And I think that gives us lots of different perspectives on what's happening in informatics, specifically related to nursing. Some of the countries, I didn't exactly know where they were, but you can't really tell because it's all the same color. But it is everywhere. So again, by country, US is the biggest. But one of the things I want to note is that we have a lot of US, and I had to do this by first author. So I did the countries by first author, but I'll say this like I did last year, that doesn't mean that's where the research was done. And a lot of these where it was clear that it was done somewhere else, I didn't do it, I did it somewhere else. But there are a lot of individuals that are from other countries that are doing this research, but yet it's encompassed within a university or some organization that's in the US. So this is a little murky as well as far as what's going on. I'm going to skip this because it's a bar chart, and we kind of know what it's saying. But it's the key here is it's relatively unchanged. The only things I included on the chart were things that were at least kind of 2% or had been on the chart before, but this is relatively unchanged from prior periods. Topic. See, this is different. This isn't an upward bar chart. This is a sideward one. I think there's a different name for this, but I'm drawing a blank as to what kind of chart this is. But this is where we get into the interesting stuff, right? So this is where we start talking about, what did I find? I read all this stuff. What did I actually hear in my mind as I was reading all these things and as I was coding all these articles? And what I found is kind of what we talked about today. I'm just kind of validating it through the research that's been done, One is telehealth and mobile. Lot of articles on that. Look at that. It's the biggest item out there. 24% of the articles I read had to do with telehealth or mobile health. All right? Big thing. If I looked at last year, I do have a bar chart on that. It was much smaller. All right? So telehealth is a big thing. The other thing I wanted to point out is that kind of way down here, sorry for whoever's recording, these two things here about technology acceptance. At some point, about halfway through reading the articles, I started to notice that we had two kinds of technology acceptance. All of a sudden, we now had the patient. And was the patient accepting the technology? In the past, we had meaningful use and physicians, and are people using it? We had everyone applying, these TAM models and other things to the providers. But now, all of a sudden, we were seeing more and more of the same research being done on the patient. Do the patients accept these new technologies? Will a patient accept telehealth? Where a patient communicate with their providers in new ways? So I separated it. So we now have two categories. One dealing with whether the patient is accepting of this technology, and one is kind of the more traditional is the organization accepting policy or the provider. So I found that very interesting, and I had to go back and recode some of them. But I thought that was an important thing. If you add them, it's 12%. So it's it's the third largest group here as far as going on. If you put that acceptance piece in there on its own. And then big data up at the top there, data use, lots of articles and discussions about that, and I can go into some thoughts on that as well. Again, back to the bar chart. There's an asterisk on transitions. If you actually pull these slides down, I do not remember why that's there. But it's there. Maybe it's important. Maybe it isn't. I have no notes on it. But it's even a little blue line. I really have no idea. If we look at this, some of the things that were of interest to me, again, was that technology acceptance. That's relatively new in the last 2 years. You can see those two lines there. There is something that I can point with probably. Telehealth mobile has been big, but it's getting bigger. Social media is starting to be bigger now, right? So that's kind of a new category. That wasn't a category we had last year with social media. That's a category that we added this year because we're seeing more articles talking about Twitter and Facebook, kind of from a couple different angles. Can you communicate that way? Can we use that data to look at flu trends like Google's doing with their Google searches? Can we use these technologies to communicate with others with? Can we have the games? I think Vicki talked about games being more things. Facebook is certainly being used a lot for games between friends. Hey, I can keep my type 2 diabetes down better than you can. So there was actually a study on that. What else did I circle up there? So big data public use is a big thing. And then public health. Again, I'm very disappointed that public health is as low as it is. We have to be doing more research, using this data, applying it to public health, buying into that social determinant of health model, and looking at these other areas of health. We can't just focus on the EHR and the medicine. We need to be collecting potentially different data in the EHR and using it to make some decisions. So next step 5 in our, again, got to have a method. So step 5 in the method is, gee, what did I find? And one of the things I want you to remember is that this was a large pool and a lot of this is on me. So if I was actually going to write a paper on this, there'd be this huge limitation that said it was just Andy, all right? And that's because this is just what came to my head. As I was reading these things, I would write things down that came into my head as I was reading the articles, and then I had 5 sheets of paper with thoughts on them, and I tried to condense them down. So there may be something up there that was in my head, but if you ask me to point to the article that says it, I may not be able to do that because it was a collective thought process. So all these things I wrote down kind of collectively meant something to me, and that's how I described it here. So one of the things I put in bold there was that the technology acceptance by the patient. That really stood out to me, that we were suddenly seeing and looking at and studying the acceptance of technology by patients. I thought that was fascinating. Because so often and all the times in the past, all those research articles have been about the acceptance by the provider or the organization or someone else, or trying to come up with a new model of technology acceptance. So there's a research study for someone out there who wants to come up with a new patient model for patient acceptance, because I think that needs to be looked at. Most of the articles really looked at traditional TAM and other type models for technology acceptance. But the first 7 of those things up there, 1 through 7, all deal with the patient. This is all patient empowerment, patient type things. So patient empowerment, technology acceptance, telehealth standards, selection of appropriate mobile and telehealth applications. That's a biggie. We learned about that from Vicki. There are so many applications out there. How do you select them? It is really hard. And so I started seeing there's a number of articles that actually talk about how you might want to start filtering that information. How might you want to start filtering these hundreds, how many, 320,000? Is that what I heard, right? How do you start filtering that? It's impossible. And who's going to tell the patient which is the right one or not the right one? And I can tell you from some of the research that's of my interest is they're not going to get that information from the provider. Right now, they're getting that information from their friends or their parents or their neighbors or someone else. They're not getting it from a health professional. So these apps that have gazillions of users and 5-star ratings are happening not because of the provider, they're happening because of where they live or who they talk to on a daily basis. Big data continues. Collaboration with nursing is key to success. I went out of order. The 8 is more important. So one of the things that was of interest was there were a number of research studies talking about how if you're not collaborating with nursing, it's not going to succeed. And they were actually able to show that and show in some various settings that if you didn't collaborate in an interprofessional way, your technology would not succeed. It would have problems and you'd have to go back and redo it or come up with a different way to think about it. So very interesting. There weren't a lot of them, but it was important enough for me to put that out there. There were a couple articles, a number of articles that talked about that very issue. You need to collaborate to get the outcomes you want. So I thought that was good. I had to put in quotes. Last year I found articles with baseball themes and sports themes, so I was really excited. I could not find any this year. I tried, I really did try. I tried to interpret the words, maybe this is some kind of sports theme or some other kind of thing, but I couldn't. But I did find this phrase called ruling practice behavior. And basically and that was from obviously a single study, but it basically summed up well what I read in a number of these studies, which is that HIT or EMRs drive process, right? So you implement an EHR, whether it's Epic or something else, and that ends up driving a lot of your choices, as far as what processes you're allowed to use. It drives how you deliver care. It can drive a lot. And it's really just kind of a cautionary tale that if you have a process that works, you've been able to demonstrate it, measure it, and then you adopt a new system, can you keep that process? How hard is it to keep the same processes that you know work? And how much does what you adopt as far as technology influence, or in this case, rule your behavior? And so there are a number of studies that talked about how we need to be careful that these technologies that we're adopting aren't changing so much what we believe is good practice. This particular article had to do with nursing practice and where nurses felt powerless and technology was being thrust upon them and it was forcing them to change their process, their workflow. And I just like that quote, the ruling practice behavior. These technologies are ruling how I do my work, and I don't like it. Talking again of some of these technologies that do with patient tools, be it telehealth, mobile health, whatever. Again, a number of studies talked about, these are harder to work in the long run. So if you do these studies over some short period of time, you can show some success. But if you then come back 7 years later, 8 years later, and look at them again, there's much less success with these technologies. And what most of the articles concluded was that you need to tailor these tools more finely than they are tailored right now. So if you can tailor the tool to the culture of the person that you're delivering that tool to, you're going to have much better success in the long run that this tool will continue to be used. So again, you can't just throw technology at something. You need to think about who the audience is, what their culture is, what they live, what they think, and how they behave in order to actually look at their behavior. It's very similar to policy, right? You can't set policy without knowing the culture and the environment with which you want to do that. America is very different from Sweden. We're going to make many different choices, so we can't just throw technology around without thinking about who we're throwing it at. And then we're using EHR data to do more predictive things. We're obviously measuring outcomes more, and that's just going to continue. And we're using the data to populate tools. And I think Dan referenced that, not directly in these words, but we have all this data. Let's use it for the things that are less important. I don't remember, important wasn't the word. What was the word? I can't remember the word Dan used, but if there are things that we just know based on the data that's out there and we can just put somewhere, that's great, because we now know that we can then put our brain power, our cognitive ability on those things that are really the nursing things, the nursing assessment pieces. All right. So there were several articles talking about how we can use EHR data to kind of predetermine or guess using artificial intelligence or predict what the behavior will be of a patient, which takes away some of the bandwidth that is in short supply in many of the nursing settings that we deal with. One other thing I wanted to add, because it came to my mind when the prior speakers were talking, had to do with the dashboards. I guess that was Dan. I keep going back to Dan, but Dan was just Dan. So was this idea of dashboards, and that you can throw all these dashboards out there all you want, unless they have some meaning behind them, unless people can understand them, it won't work. There were a number of studies out there that said that, but there were only 2. And basically what they did was they were actually able to demonstrate that if you could provide a dashboard that provided answers or measures on a small set of specific things, it provided much better information to nursing and other professionals than having that information within the EHR. So if you were able to take data that was in the EHR, translate it into 5-6 things that you could say were important for that particular day. It's not a week ago, it's not a month ago, it's real time. That was much more valuable and provided much better outcomes for the patients that were on that floor versus a different unit. So that popped into my head as we were talking about it, and I can provide those 2 articles to anyone who's interested. All right, so these are some representative citations, but again, going back to my prior statement, I was really just jotting down themes as I read through all these, and then trying to go back and pick some articles that more broadly represented those themes was very difficult. These happen to be a couple of them, and I'll just kind of give you the gist of what each one of those was trying to say. So the first one was talking about variation in health needs, that idea that not everyone's the same. You can't have the same plan of care for everyone you treat, all right? You need to look at some differences. You need to look at the patient. You can't just look at the monitors and the numbers. You actually need to walk into the room and look at the patient, and there's going to be variation in that. Next one had to do with the one I talked about before, with the EHR, other technology basically influences the processes that you have. The third one that's up there, and again for time I'm not reading them all, is that you must understand your population for anything to be effective. I think I've said that twice or 3 or 4 or 5 times now. Training and support is a greater issue than you thought, right? So you can't just roll something out without that training and support. So there was a lot of articles that talked about, gee, training and support is really important. I didn't realize how important it was until everything just fell apart at the end of the day. So training and support is really important. This is an article that had to do with secure messaging and how people communicated with their providers. And what this article basically generally found was most of the messaging taking place now is patient forced, right? So it's all coming from the patient to the provider. Very little is coming from the provider to the patient. And that's something that I think will evolve as well. As we get more predictive information or other kinds of information that will be useful to the patient that only the provider knows, they can start pushing that information back to the patient. So the patient knows that they should be monitoring this, or gee, I happen to notice, especially with all these measurement things, gee, I happen to notice your blood pressure has been higher for the last 3 days. Why is that? Well, I'm not taking my medication anymore. So, and then the last one is also looked at communication. It looked for patterns of communication, and basically put everything down into kind of 6 patterns of communication using Facebook. Now, again, this was written before all this Facebook stuff, but they looked at communication. I believe this was around again, type 2 diabetes, and looking at how people communicated. And most of the communication was, again, between peers, right? So very little of the communication, and it wasn't just Facebook that they were using, literally little of the communication was back to the provider. So people were learning and supporting each other with their peers, which may or may not be the best way to do it. It may be good if it encourages everyone to do more and it kind of increase their healthy behaviors, but if that's your source of information, that may not be the best thing. And then step 6 of the model of our method is consultation, and that's your feedback. Did I do it in a half an hour? Okay. All right. Any thoughts? Question? Oh no! She hasn't put done yet up. I still have time for some questions. And oh no! Are there any thoughts, questions, feedback? Nicely done. Thank you. All right.